good afternoon or good evening for the participants and the speakers. And today it's my privilege to be one of the hosts of this webinar, and the program, as it was mentioned in the email, the discussion about long-term medical treatment of endometriosis, evaluating the role of the Diczfalusy combination therapy. And will be two presentations: the long-term medical therapy for the endometriosis pain, presented by Professor Gernot Budelis, and insight into the SPIRIT trial, presented by Professor Ida Petka. Now I would like to introduce the first speaker, and we agree with the speakers that the discussion will be after the two presentations. Professor Gernot Budelis, full professor of the Medical University of Vienna, consultant of Gynecological Hospital St. John of God, certified tertiary referral center of endometriosis, clinical fellow minimally invasive gynecological endoscopy, honorary clinical fellow gynecological oncology, head of the certified center for endometriosis and pelvic pain, certified master surgeon, minimal invasive surgery and endometriosis care, and certified neuropelviologist. He is elected board member of many international societies, and he is expert in endometriosis, gynecological oncology, laparoscopic surgery, and ultrasound. Professor Budelis, the floor is open for you. We are waiting for your presentation.
Yes, dear colleagues, dear organizers, thank you very much. Can you hear me? I will share my screen now.
Definitely.
And you again, please briefly let me know whether you can hear me clear.
Yes.
And sufficiently. And I will start sharing my screen. Just a second. It should work.
And during, I will ask all others to turn off microphones, please. Everyone.
Can you see my screen now?
Yes.
Excellent. And can you see my first slide?
Yes, full screen.
Wonderful. So again, thank you very much for inviting me to this webinar. And my task today is to provide you an overview of the current standards of medical treatment for endometriosis pain. So if we talk about medical therapy for endometriosis pain, we have to face the fact that endometriosis is quite a common disease or disorder that affects then the varying prevalences in the literature between 2 and 11% of the reproductive female population. This does not imply that every woman with endometriosis is severely symptomatic, but a relevant number of these patients will face chronic symptoms of menstrual and non-menstrual pain, deep dyspareunia, and associated comorbidities like psychological stress, reduced quality of life, and possibly also fertility issues. The basic options are expectant management in patients with little or any symptoms. It may either be medical therapy or surgical resection of disease. So our task today is to look at the issue of pain. And the current version of the guideline of the European Society of Human Reproduction and Embryology, where I'm honored to be a member of the guideline group and committee, clearly states that there are different treatment options, and depending on the individual preferences, there is the option of surgical resection, of hormonal treatment, and of analgesic symptomatic treatment. The problem with pain issues in women with endometriosis, and I think we have to bear that in mind, is the process of the development of visceral hyperalgesia. So what is visceral hyperalgesia? It is a mechanism that has to do with neuroplasticity and the fact that in patients with a chronic pain stimulus, we experience a shift towards a response with a lower pain threshold. So the less intense the stimulus may be, and even in the absence of the cause, we will still have a pain sensation. And the longer the stimulus is present, the more likely these patients are to develop a chronic pain problem. As a consequence, the sooner we are able to deal with the pain, the more likely we are to lower the risk of pain sensitization and visceral hyperalgesia. So what are the current recommendations? And let me briefly give you an overview of the current standards of medical treatment of endometriosis. Women may offer non-steroidal antirheumatics, either alone or in combination with adjunct treatments. And this recommendation is rather weak because we have little evidence for NSAIDs to work in endometriosis-related pain, but this is basically due to a lack of interest in performing these studies. We all know that non-steroidal antirheumatics offer a good treatment option for moderate dysmenorrhea, and ideally it should combine with a long and a short-acting non-steroidal antirheumatic drug like ibuprofen, etc., in combination with short-acting metamizole drops, for example. Secondly, we do have a strong recommendation that the medical treatment of endometriosis should entail combined oral contraceptives, progestogens, or GnRH agonists or GnRH antagonists. These medications should be offered taking into account pros and cons, benefits and side effects, and be recommended in a shared decision-making process. If we look at the evolution of medical treatment options, we can see that hormonal therapy for endometriosis reaches back up to the 1960s in form of pharmacological treatment. And as you can see, oral progestins have been described from the times where the oral contraceptive pill has been developed, but the official use of these preparations have only been recently been allowed regarding the fact that it's long been used so-called off-label. In the 1990s, there has been an evolution of GnRH agonists. Around the millennium, we see an increase in use of long-acting progesterone preparations like the Mirena coil and SERMs. And until recently, GnRH antagonists have been developed and recently transformed into clinical practice. The future may also include additional medical treatments like PEA, melatonin, or cannabis preparations, and possibly personalized medicine in order to define a certain endometriosis phenotype that may be more or less likely to respond to certain pharmacological agents, similar to oncological therapies. This may be the near, or hopefully be the near future. So how do these preparations act? And apart from non-steroidal antirheumatic drugs, which basically lower pain thresholds, we can see that oral progestins and combined oral contraceptives predominantly inhibit the hypothalamus, to a lesser extent the anterior pituitary gland, and reduce estrogen production. This is a similar way GnRH agonists act, because following initial receptor stimulation and gonadotropin release, we have a subsequent receptor desensibilization and a lowering of the GnRH hormone, and thereby lower LH-FSH levels and lower ovarian estrogen and progesterone production. In contrast, GnRH antagonists clearly antagonize the receptors as such, whereas long-acting intrauterine devices like LNG IUDs such as Mirena, etc., or also other preparations like Jadis or Levocert might directly act locally and inhibit cell proliferation, stimulate cell atrophy and apoptosis in endometriotic lesions. So if we look at the hormonal therapies, it is clearly recommended to prescribe a woman combined oral contraceptives, either oral, a vaginal ring, or transdermal, to reduce endometriosis-associated pain symptoms. Women suffering from endometriosis-associated dysmenorrhea can be offered the use of such combined preparations. Similarly, progesterone-only preparations can be prescribed, and head-to-head studies show nearly equivalent reduction of pain symptoms, either by using COCPs or progestins. Equally, progesterone preparations can be used as a long-acting local device like Levocert, Mirena, etc., and will equally reduce pain when compared to GnRH agonists or COCPs or progesterone-only preparations. Currently, the use of GnRH agonists is recommended as a second-line therapy, especially if hormonal contraceptives or progestins have been ineffective. Why? Because we only have limited capacity to prescribe GnRH analogs, A, because of their side effect profile and induction of postmenopausal symptoms. So ideally, these preparations should be prescribed with hormonal add-back therapy to reduce or prevent bone loss and a hypoestrogenic state. And secondly, because of their limited capacity or capability to be used as a long-term treatment solution. Recently, GnRH antagonists have been evolved, and my colleague will report on these data so far. Predominantly, data are present for relugolix and to a certain extent for linzagolix and elagolix. These are oral preparations that directly antagonize the GnRH receptor and have been shown to be highly efficient in reducing endometriosis-associated pain. Based on the fact that the evidence is still limited to the SPIRIT trials, the Guideline Committee recommends to use GnRH antagonists as a second-line therapy in cases where hormonal contraceptives or progestins have been ineffective, either due to a loss of effect or due to their side effect profile. So, if we now would like to avoid recurrence of endometriosis following surgery, and this is a different scenario, hormonal preparations equally are recommended to reduce the risk of recurrent endometriosis and recurrent pain issues that are very common following surgery, even if the disease has completely been removed. So at present, there is a strong recommendation to use either a levonorgestrel IUD or a combined oral contraceptive as a secondary prevention for endometriosis-associated dysmenorrhea following surgery. Especially following removal of ovarian endometriomas, in women not seeking conceptions, clinicians are recommended to offer long-term hormonal treatment like COCPs for the secondary prevention of endometriomas. What is the current evidence on which preparation to use following in order to prevent recurrence? And so far, there has been no evidence on that until recently, where the so-called PREEMPT study has been published in the BMJ just 2 weeks ago, where the aim was to compare long-acting progestins like the LNG IUD or subcutaneous depots versus oral combined contraceptives in order to test their effect on reduction of pain recurrence following surgery. In this study, 405 women were randomized with predominantly stage 1 and stage 2 disease to either receive long-acting progestins or COCPs. At 3 years, there was no difference in pain scores between both substance classes. And there has been a general reduction of pain compared to the pre-surgical values of up to -40%. A small advantage was observed for long-acting progestins when compared to COCPs with regard to additional treatments required over the observation periods, with an absolute difference of 7.6%. However, as you can see, there was little adherence to the primary treatment recommendation. Adherence to treatment was only observed in 56% and 48% of participants at 1 year, and even only 26% and 25% at 3 years in the long-acting progesterone and COCP group. So as a consequence, we also feel a lack of adherence to hormonal therapies, possibly due to side effects that face or reflect a problem in long-term medical treatment of endometriosis-associated pain. So the problem with hormonal treatment options are a rather high dropout rates of up to 30 and post-surgically up to 50 to 75%. The second problem with hormonal treatment is, if we look at progesterone and COCP preparations, that we face progesterone resistance in patients in up to 30%. So over the period of 2 years, 30% of patients who receive medical treatment in form of progestin preparations or combined oral contraceptive will develop resistance to the drug. And finally, hormonal preparations act as contraceptives and are contraindicated in patients who wish to conceive spontaneously. So coming back to alternative treatment options, there have been some studies ongoing on the use of melatonin. However, so far, the only studies that have been performed on melatonin are not sufficient to recommend their general use. Similarly to palmitoyl etonolamide, which has been shown analgesic effects, but has so far not been recommended in clinical practice. Cannabidiol preparations that could be used as an adjunct to non-steroidal antiaromatics appear to be efficient, but large RCTs are still pending. So let me summarize my recommendations. At present, the mainstay of medical treatment of endometriosis pain consists of analgesics that should be used as a first-line therapy, possibly or ideally for pain management in combination, if necessary, with hormonal preparations. The aim of hormonal preparations is to reduce peripheral estrogen levels and to decrease endometriosis-associated inflammatory states, stimulation of nerve fibers, and therefore reduction of pain. The first-line treatment consists of the continuous use of combined oral contraceptives, ideally oral, vaginally, possibly transdermally, and a state of amenorrhea in a long cycle or long-term use fashion should be aimed for in order to decrease or eliminate menstruation. Similarly, progestins have been shown to be highly efficient. These progesterone-only pill preparation can be applied orally or in form of LNG intrauterine systems. However, side effect profiles need to be considered, like mood swings, mood disorders, or intermittent bleeding disorders. At present, second-line treatment options consist of GnRH agonists, but their role is more and more diminished due to relevant side effect profile and the fact that they are no long-term treatment option, even if combined with ADVEC therapy. The substance classes that have been developed over the past decade include GnRH antagonists, which provide a new substance class which is currently recommended as a second-line treatment in cases where first-line treatment options have failed. Evidence is so far limited but evolving and need to be taken into account. The present data suggest that GnRH antagonists do not entail a considerable risk of bone loss, especially in case of relugolix. So my take-home message to you is that the current approach to pelvic pain associated with endometriosis is personalized and includes a combination of hormonal and non-hormonal medicines. Symptomatic women with suspected endometriosis not wanting to conceive should be offered a combined oral contraceptive pill or progestin. This also should apply to post-surgical recurrence prophylaxis in patients not aiming for conception. The first-line hormonal suppression is either inappropriate or ineffective for a number of endometriosis patients. We have to face progesterone resistance, which is a relevant problem, and there is a need for improvements of suppressive and hormonal treatment options. Relugolix and risperidone are the two latest suppressive medications that have been evaluated and have been shown to be efficient in reducing endometriosis-associated pain. Further research on these preparations and alternative medicines, as well as possibly personalized treatment options and phenotype-related individualized treatment plans are needed and are ongoing. Thank you very much for your attention.
Much for the presentation. I think your presentation will generate a lot of questions. and it was a very nice overview of the actual situation of the endometrial treatment. Before we go to the question and answer, we would like to listen the second speaker. And now I would like to introduce Associate Professor Ida Petka, who professor at the University of Bucharest, the Elias Emergency University Hospital in Bucharest, invited speaker and experts in pelvic floor reconstruction and female incontinence surgery, as well as perinatological advanced diagnostic ultrasound. She is the principal investigator of several national and international studies, member of the editorial board of the Romanian Journal of Emergency Surgery, and she has quite many affiliations, like the American Association of Gynecological Laparoscopists, Romanian Society of Urogynecology, or Romanian Society of Minimal Invasive Surgery. Now she would like to speak about the SPIRIT study, and we are would like to listen your presentation. The floor is open for you.
Just a moment before Professor Hudalis, your screen sharing is still on.
Pardon?
Hello? The previous screen sharing is still on, and
So hello, I had the mic off. Thank you, Professor, for your kind words, for your presentation. And now I'll share my screen. Do you see it?
Not yet.
Not yet.
Not yet. Before the previous sharing is still on, but I will try to solve in my way, unfortunately. Okay, please share your screen now.
Just a
Yes.
moment.
Yeah, no, it's okay.
It's okay.
Is that better?
No, it's the editor screen.
Okay, like this. Is it okay like this?
No, it's still on the editor screen. You can see. You should share your desktop first and then start the PPT.
I start my desktop first.
Yes, yes.
Sorry, but.
So remove the share.
Yes. So the whole screen.
Yes. It's your desktop. Okay.
Better
Now it's okay. Thank you.
It's okay.
Perfect. Thank you.
I'm sorry for that. A minor distraction before I follow with my presentation. So I hope I'll convince you about the product that I know for a few years, as I have been involved in the SPIRIT 2 trial. And hopefully at the end of this presentation, you will all know more about this Relugolix combination trials as a result of long days of working with the patient from the study. So in a few words, what should be said about the burden of the endometriosis is that it affects a big percent of women of reproductive age, roughly attaining 119 million people. So this is a lot of people. Up to 75% of them have moderate to severe pelvic pain. Still, we see women who encounter great delays in diagnosis, up to 11 years between the first symptoms and the final diagnosis. 50% of those patients who have received a kind of treatment have recurrence. This means that new medical treatments are needed to improve the lives of these women. So what is relugolix combination therapy? So in short, it's a pill who is administered once a day and who contains relugolix, 40 milligrams, 1 milligrams of estradiol, and 0.5 milligrams of norethisterone acetate. And now this association, this combination, is approved, as we all know, for more than 2 years for treatment of moderate to severe symptoms of uterine fibroids in adult women, as well as for about a year for the symptomatic treatment of endometriosis in women with a history of previous medical or surgical treatment for their endometriosis. So in the following slides, I will describe some key details from the SPIRIT program. As I told you earlier, I was involved in the SPIRIT 2 program. So over 2,000 women were involved in the first screening and then were randomized in 3 groups: placebo, relugolix combination therapy, and relugolix combination therapy after a period of relugolix for 12 weeks, so the delayed relugolix combination therapy. And what it is important to be seen in this slide is that both trials took place in about the same time in 5 continents, over 220 sites in 21 countries. So a lot of people was tried to be covered. So we all know that the pill at the end of the trial will be useful for an efficient treatment for diverse population. At the end of the 24 weeks, we had more than 1,000 patients who reached the primary endpoint assessment. In these 2 pivotal studies, women between 18 to 50 years of age were enrolled that were surgically diagnosed for their endometriosis. This was a compulsory and necessary point, so the patient could be enrolled in the study, which demonstrated moderate to severe dysmenorrhea and non-menstrual pelvic pain prior to the randomization. And what it is important to be said here is that patients who had the BMD Z-score minor than 2 at the baseline for lumbar spine, total hip, or femoral neck were excluded from the study. And I should say here that young patients, thin patients, were excluded because of that particular reason. So we may have surprises whenever we assess the bone density of a young woman. So it would be a nice step to take whenever some doctor considers to administer relugolix combination therapy to a young, slim patient. And after that, there was a spirit extension trial for another 80 weeks in which 800 patients entered and 802 quite. All of the patients were on relugolix combination therapy. So whenever somebody chose to stay in the trial and had no desire to obtain a pregnancy, they remained into this trial. So we have almost 2 years to see about the efficacy and about the side effects of the treatment. So about the study, it's important to say that the co-primary endpoints assessed by the numerical rating scale were proportion of dysmenorrhea responders and the proportion of non-menstrual pelvic pain responders that were defined in these trials as women achieving a mean reduction of the NRS scores of more than 2.8 points for dysmenorrhea or more than 2.1 for non-menstrual pelvic pain. And an important fact, no increase in the use of analgesic medication recorded in the daily e-diary. I should mention a few important facts about the demographics and the baseline characteristics of the women involved in the trial. As you all may see, that the mean age was kind of the same in the whole in all the spirit trials, in all the groups, about 34 years of age. And most of the patients have had been diagnosed in less than 5 years before their screening. And it is important to note that in that pre-randomization period, in the screening period, which lasted for 35 days, about 60% of the patient displayed a numeric rating score for dysmenorrhea of more than 7 points and a non-menstrual pelvic pain score more than 4 points in almost 80% of the patients. And of course, both Spirit 1 and Spirit 2 showed an increased and significant use of analgesic. I must highlight here that almost 50% of the patient had, as we've noticed from their surgical data, that had minimal and mild stage of endometriosis, which does not imply that endometriosis, mild stages of endometriosis, do not associate with great and severe pain. So this is a known fact. So these were a few words about the population from the study, but it is important to discuss from now on if the product works, as we have found out from the study. One of those co-primary endpoint, which was dysmenorrhea, proved that women in the group with the product, with the relugolix combination therapy and the delayed combination therapy, reached almost 70% reducement in the numerical rating score of more than 2.8, as discussed in the beginning of the study, and about the spirit extension at week 52 and 104, more than 80% of the patients enrolled displayed a mean reduction in the NRA score of more than 2.8. This is an important achievement, I think. This is a really nice slide, which shows something really simple, that at 8 weeks and at 24 weeks, dysmenorrhea decreased in the 2 intervention groups and stayed low. Even a greater extent we see in the extension, spirit extension. And it is important to see that dysmenorrhea dropped on an average 5 points on the NRA scale at week 24. This is an important achievement, as we can see here. The second co-primary endpoint was the non-menstrual pelvic pain, and we may see that that was obtained in both trials in almost 60%, roughly 60% of the patients, with an NRA score of more than 2.1 for this co-primary endpoint, which increased almost in all the patients at about 70%. And an important fact is that we have not noticed an increase in the analgesic use. As you may see about the non-menstrual pelvic pain, another visualizing graphic is that from the baseline, we may see a 50% reduction of the non-menstrual pelvic pain. It is about 3 points on the scale, which is even greater at the end of the spirit extension, almost 70% reduction from the baseline to week 104. This, I think, is great news. The study had seven key secondary outcomes. One of it was dyspareunia, which decreased from baseline over the first 24 weeks with almost 40%, and attained almost 60% reduction at week 104 when compared to the baseline. Another key secondary outcome was not using analgesic. As you may see at baseline, only few patients were not using. That's why our minimal numbers here, not using analgesic, and those numbers are quite high at the end of the week 24 and higher even at the end of the week 104. We all know that a big problem of endometriosis is daily functioning, which is measured by AHP 30 pain domain score, which improved by the week 24. And hopefully it improved even more after 80 more weeks, reaching a 72% improvement in the quality of life. So, as I think I was quite clear that the product works, but it is about safety, which is quite important when dealing with the disease that necessitates a long time treatment. When we see the cumulative adverse events, we observe that hot flash appeared quite in the same percent for placebo and relugolix combination therapy. It is, of course, a greater extent for the relugolix delayed combination therapy because there were the first 12 weeks that had no ADVEC therapy, which is important, of course. The incidence of adverse events with the relugolix combination therapy was similar to that observed with placebo at week 24. But it is important, as we may see, that headache and nasopharyngitis was the most prevalent complications. It is important to know that within a study trial, everything that happens to a patient must be noted, no matter that complications, that side effect is linked or not to the study medication. It's not important, that fact. So as both study trials began in autumn and passed through a winter, it's important to understand why headache and nasopharyngitis were the most common within the trial. Other safety aspects over those 2 years is that no clinically important differences were evident in vital signs, including blood pressure or laboratory parameters, including liver function test and lipids. And at the end of the 2 years, minimally or clinically insignificant changes in blood chemistry parameters, glucose and lipids are observed. No significant effect on cardiovascular system as blood pressure or heart rate observed. To note, the last 2 boxes is that we found no effect on weight and no mood swings. A crucial fact, I might say, when we are thinking about prescribing a GnRH receptor antagonist is bone mineral density. And as you may see, exception made by the first 12 weeks where relugolix were administered by himself, the bone mineral density stayed at a satisfactory level. It might be an important question. What about contraception? Because these women are young women. An open label single cohort study has the answer for this question because they enrolled 71 patients for a period of 84 days. Each day was administered one tablet of relugolix combination therapy. All patients were assessed with transvaginal ultrasound and hormonal profiles, LH, FSH, estradiol, and progesterone every 3 days. And 67 patients, met the final follow-up visit, and none of the patients ovulated during the study. This might be explained by the fact that with the combination therapy, the mean estradiol concentration were maintained at comparable levels from the early follicular phase of the menstrual cycle as a result of the profound suppression of ovarian estradiol production as part of the relugolix using. So none of the women ovulated during the study treatment. And which is also important is that all participants returned to ovulation or began menstruation within 36 days after treatment. And we had a mean time to ovulation of 23.5 days. So in conclusion, I recommend relugolix combination therapy as well tolerated after 2 years of evaluating over 2,000 patients. It is well tolerated with an overall incidence of adverse events similar to placebo. And it is important that it demonstrated statistically significant and most important, clinically meaningful improvement in dysmenorrhea, non-menstrual pelvic pain, and dyspareunia after 3 years of treatment. And I think that we may agree that it represents a potential long-term treatment for women with symptoms associated with endometriosis and has the potential to minimize the need for repeated surgeries. Thank you.
Thank you very much for your excellent presentation. And I think now it's time for questions. And independently from the... So you can pose question to each speakers. Do you have any question either to Aida Petra, professor, or the first speaker? For the time being, when you think about question, I have one question to Professor Aida Petka. Namely, one of your slides, you mentioned that quite long time elapsed the symptoms onset and the first treatment. As you mentioned, it's sometimes between 4 and 11 years. What do you suggest? How can one accelerate the diagnosis? How can you decrease this tremendous time?
Well, it's mainly, I think, a matter of experience of the doctor that consults the patient. And I saw many patients which consulted lots of doctors, and important is the fact that they contradicted themselves. Somebody said it might be endometriosis, but we say that to a patient that has 18 or 19 years old, and a few years ago, when you had to diagnose it through an operation, it was difficult to propose such a young patient to operate to know if she has endometriosis or not. So once, as my previous speaker said, you propose to somebody to take contraceptive pills or progesterone-only pill for such a long time, they don't want such a treatment. So mainly it is the fact that they are afraid of the side effects of the treatment. They do not believe that the disease itself is so bad that it could affect on the long term their lives. And it is important to note that some doctors, colleagues of mine from Romania, I don't know in other countries, but I've seen patients I had in the study, in the trial, patients which were treated with antibiotics and non-steroid anti-inflammatories for 12 or 15 years, which were ineffective, of course, and had also side effects.
Thank you very much. And I have a question. Peter, do you want to ask something?
Yes, thank you for the opportunity. Thank you for both presentations. I'm an infertility specialist, and I actually have two questions. One of them is it's not quite related to this topic, and if you don't want to answer to this question, that is all right. But where do you see the role of surgery for the more severe stage 3, stage 4 endometriosis cases related to infertility? And the second question I have is GnRH agonist is often used prior to embryo transfer, especially in patients with adenomyosis. Do you see a role for GnRH antagonist instead of the agonist for the same purpose, giving it before embryo transfer with patients with severe endometriosis and adenomyosis, which often come hand in hand?
These are questions for me, yes?
Both.
Sorry, to you or both of you?
Okay. So if I'm a woman, I might answer first. So
Yes, of course.
yes, we all know that deep endometriosis does not have definitive solution beyond surgery. So it's complementary, but it cannot replace surgery. This is my opinion. You asked for my opinion. And about the use of this product in infertility problems, I already used it because I knew about the product. It is on the market for fibroids for 2 years. I convinced the patient that I have experience with it, and she went along with my recommendation, and she got pregnant. So I did prescribed it already for adenomyosis.
Peter, is it the answer to your question?
Yes, it is. To the second half, regarding the surgery, I often see patients who come to us after the surgery, and I always wonder what the indication for the surgery in their case is, because my understanding is that medical therapy should be explored before surgery is offered to patients with severe endometriosis if they are symptomatic. If they are not symptomatic, they really don't need surgery or medical therapy. And surgery is really indicated for severe pain, bowel obstruction, urethral obstruction, so for the really severe complications. And some of these patients end up having really poor ovarian reserve, and then we are stuck with someone who had major surgery, and now we cannot help her with IVF because she has reduced ovarian reserve. So this is why maybe the question was a little bit provocative, but I was wondering what the situation is in other countries. Thank you.
Well, can you hear me?
Yes.
Yes, yes.
Well, let me respond to the question as well, if you would like to. So
Yeah.
the first question is regarding GnRH antagonists and IVF. Although I do not do IVF, we have to look at the data that support the pre-cryotransfer application of hormonal therapies in order to enhance live birth rates. And the current ASHRA guideline does not clearly recommend this. The data are very conflicting. There are some studies, mainly from China, who have shown an increase in live birth rates due to the application of GnRH agonists for 2 to 3 months in patients with deep endometriosis and adenomyosis, which may result in a higher live birth rate. So I think there may be a role in a selected cohort of patients where a cryotransfer is planned, and in patients who do have severe adenomyosis as well. There are currently no data regarding the use of GnRH antagonists to achieve such a result. So studies are needed. The other question is, which patient should be operated? This is,
a question you could fill a congress with, but the role of surgery in infertility patients is the one where patients are below the age of 35, a good sufficient ovarian reserve with an MH of at least above 2.5, little or any adenomyosis, and the clear aim to achieve a spontaneous conception, plus pain symptoms. I think these patients are eligible for surgery performed by an experienced surgeon. Other patients should be offered long-term medical treatment and ART or IVF. There are no randomized controlled trials regarding ART, IVF versus surgery for deep endometriosis in order to achieve higher or worse live birth rates. But the current evidence suggests that both, and especially ART, is efficient for patients infertile with deep endometriosis.
Thank you very much, your answer. And I have a question to you. How frequently there is endometriosis behind the vulvodynia in your practice? And which kind of treatment, which kind of connection do you find between the vulvodynia and the endometriosis, and the endometriosis treatment can sufficiently treat the vulvodynia?
I think we have to distinguish between vulvodynia and deep dyspareunia. Vulvodynia has, to my best knowledge, nothing to do with endometriosis. There is a correlation between deep dyspareunia and rectovaginal endometriosis, but this is all we know.
Thank you. So you think that there is no any connection with the vulvodynia and the endometriosis?
Well, vulvodynia will mean pain in the vulva area.
Yeah.
In the vulva area.
Yeah.
I do not have any knowledge of data supporting a link between endometriosis and vulvodynia. There is a clear link between deep pain with penetration during intercourse, deep dyspareunia, and rectovaginal endometriosis. This has been shown to a sufficient extent. But to my best knowledge, I do not observe a correlation between vulvodynia and the presence of endometriosis.
Okay, okay, thank you. Any question from the participants? So, how long time do you treat with the patient relugolix in the chronic therapy? What do you suggest?
I think this is a question for my colleague.
Yeah.
Thank you for redirecting it. So, as I have presented earlier, we know that it's safe to be administered for 104 weeks. But I have a few patients that have taken the drug longer, and I will explain why. They were in the trial. The trial ended. The medicine appeared. Now it's novel. It's an open label medicine, and they are once again on the drug. So I have a patient which took totally about 36 months relugolix combination therapy. 36
months. And
yes.
So far, perhaps there is no experience.
I learned my lesson about some elements to be evaluated. As I said during the presentation, it is important to assess the bone mineral density of each young, healthy woman if she is slim, because they have low bone mineral density. So I'm assessing that, and I assess at 6 months those parameters, blood parameters, to notice if anything changed, and nothing important so far.
Speaking about the side effects, if you compare the relugolix treatment with other type of treatment, do you have any difference? And especially you mentioned the hot flushes. One of your slides, it was that it was about 40 with a simple relugolix treatment, and the combination was the side effects in the, speaking about hot flushes, was just a double. How can you explain this?
I noticed within the trial, I mean, and I understood that the patient was on that relugolix combination, on the delayed combination therapy. So those 3 months without the add-back therapy. So this is an important fact that explains the hot flashes. But I've noticed that in some patients, in the 3rd or 4th month of treatment, some of them experience hot flashes that go along without any kind of intervention, but they may experience a few days of hot flashes after 1, 2, and 3 months of treatment without any hot flash.
Thank you very much.
There is a question in the chat box, if you can see, Professor Bartfai.
Pardon?
Or the speakers, of course. On the upper side, you can click on chat and you will see the question.
So, who want to join to the discussion? I can see anyone.
I see that somebody asked if Rieco is a good solution for adenomyosis. It's not within the RCP, but I used it. I mentioned it earlier, and of course, my experience is not sufficiently wide, I might say. I have only a few patients that I placed them under Rieco, but they are okay about the pain. And what is most important, one of my patients obtained a pregnancy after the treatment, which was prescribed for adenomyosis. But it's one patient, it's not a lot.
Thank you. Any other question? So, I can't see anyone who would like to pose question. So I would like to summarize. You know, we have heard 2 excellent presentations, and I am convinced that this treatment modality is a very successful one. But also we know that we need further studies to investigate the effectiveness of this treatment, and the SPIRIT trial is rather convincing. So I think we now have a very good treatment in our hand to treat the endometriosis. Do you want to ask anything else or comment? If not, I have to say many thanks for the speakers, and I wish you a pleasant evening. Goodbye.
Thank you also for the invitation.